Hi everyone, I'm Jen Brewer. I'm the Wound Ostomy Continence Nurse here at the Collingwood Hospital, and today we're doing dressing selection. So I like to start with functions of dressing. So what do they do? So that is really the big thing with actually choosing dressings. You want to know why you're doing the dressing. Again, if you're trying to add moisture, remove moisture, or maintain moisture. That's how I tend to categorize them so that it's easier to kind of understand and use them. Again, are we trying to fill dead space? When we have a big pocket, we're packing it, so we want to try to be able to get an agent usually to the bottom of the wound. We're promoting autolysis, and then moisture balance is the big thing. So we always want a wound to be not too wet, not too dry, just right, like the inside of your eye. That's that balance piece. So often I'll do a consult, but if something's changed drastically in the time from when I've seen them to the time now, like I do like that you are able to try to change up the dressing and at least know what they're for and how to make those choices. Again, we're going to try to provide antimicrobials to critically colonized wounds, and the goal now is to actually reduce dressing changes. We don't no longer the days that we do BID, wet to dry. We still have an old surgeon that sometimes tries to do that, but we do discourage it. So you'll see in the OR and on the surgical floors, we actually use Aquacel Surgical. So it's a dressing that can actually, when they first promoted it, said it could stay on 2 weeks. We're changing it weekly now, or that's what the company's promoting. But we are going to see a lot more dressings nowadays that we're leaving on for those that week at a time. We also have some negative pressure dressings that we have that choice with. Some are like a Pico, Avella is the different brand, and we also have Provinas, so incisional dressings that, again, they stay on for at least a week. So we'll go through some of those in here. So wound cleansing. Wound cleansing is probably one of the most important pieces to doing a dressing change. Gone are the days that we do wipey swipey that we were taught back in school, where you got your 4 gauze and you're trying to take the forceps and get them all balled up, and then you're gonna go and wipe the bacteria that's on the one side of the wound onto the other. So irrigation has been the primary thing that we want to do for most wounds. Of course, if it's a traumatic injury, or we're trying to keep a skin flap from a large skin tear, yes, we're going to do a normal saline compress where we will put some saline on gauze and just do a compress, and or if it's painful. But the other 90%, really, we want to be using these bottles. The reason why they do have a pressure, so we want to actually really irrigate that wound and use that pressure to actually remove debris out of the wound. So most people don't actually use it like that. So you'll often see Jen in a lovely little yellow gown because there's spray everywhere because I'm irrigating out the wound, especially big holes and bumps. So again, this has a PSI of 8 to 15, so it depends on how far away you are, but you really do want to be irrigating it. So for the most part, I actually usually take abdominal pads because they're probably the cheapest, and I'm covering over and I'm irrigating the heck out of these wounds because it really does help to clear out the debris. The only product that we carry that you would use sterile water for is Acticoat. It's the only one because it's a crystal-based silver versus the rest are silver-based or metallic-based. And I didn't get the bottles for that just so they never got mixed up. But you can use still the good old blunts and a syringe to irrigate if you need to in those cases. But yeah, so irrigating is a really big piece. That's why I spend so much time on it, because again, I do want to see people irrigating wounds versus good old wipey swipey. Okay. So again, the moisture balance I did talk about is that we want it not too wet, not too dry, just right like the inside of your eye. And again, that's the key for dressing selection, and in that add, maintain, or remove moisture. So I start with dressings that add moisture. So we carry now Intrasite, because NuGel's on back order. We lost Tegaderm Hydrogel. This is like Kendall's off-brand Normagel. So if you've seen any of these other gels in where you are, they all do the same thing. They're all hydrogels. They're literally just a bit of saline and, like what's the stuff that we mix to thicken. It's basically the same type of stuff. So this gel is going to help to hydrate an eschar. It's going to hydrate, anything necrotic. Now, we also have to be aware there's certain necrotic things that we don't want to hydrate. So for the most part, this is, on a skin tear or something that's dyed, that's kind of anterior. If anything's below the knee, you really want to know if you should be hydrating that first. So that's really my caution. I'm like, this is kind of from the knee up. you can you can hydrate just about anything that's necrotic. Just yeah, anything below the knee, we won't be doing that. And use lots. That's another big thing. I find nurses, we just go, oh, okay, we'll put a little bit on. And I'm like, oh, I just. If you're hydrating something really black, especially the bums, like when we get big bad ones on bums, like sometimes I use like 3 of those. So it depends how big it is, right? So don't be afraid to use lots. It's not like it's going to harm it. It's just to hydrate it. There's a little bit more all the other jargon about it, which I just kind of talked about. So Bactiguard I have here the most as a that I use. It's because it's petrolatum based and it has a 2% chlorhexidine in it, so it's got a bit of an antimicrobial. Instead of Gelnet, I actually carry Adaptic, mainly because they want us to use Adaptic under negative pressure. But and again, Adaptic doesn't add a whole lot. It's just more of a contact layer, so that when you take off your old dressing, you're not tearing the tissue with it. So that's really what you would use a contact dressing for. Bactiguard sometimes we will just use for incisions, but again, it is when you just want to add that little bit of moisture. And because the petrolatum is an emollient, the emollient sometimes is very soothing to around surrounding skin. So you don't always have to cut it just to the shape. Sometimes it is okay to drape over the peri wound and use that. Often I will actually use 2 layers of Bactiguard versus 1, so that you can leave it on for a couple more days. Bactiguard can stay on up to 3 days, as well as the Adaptic. Adaptic, we have it in like these huge sheets. I do have it in the box, but then there's like 3 sheets in it, and then it also comes in a small square, so it just depends on how much you're going to need. Bactiguard I do have in 4x4s, but as well as 15 by 20, or I think it's a 6x4. So if you have a really big area, you can use it on there. And again, all the same stuff. Dressings that maintain moisture. So acrylics are one of my favorite dressings, mainly because they replaced old Duoderm, which old Duoderm was, a lot of people actually reacted to. There's about 30% of people that were quite allergic to it, and it was really smelly. Oh, I didn't put one new one in. Anyways, that's the package for it. The clear acrylic will actually puff up and absorb a bit of drain. It used to be called a Tegaderm absorbent. They switched the name to clear acrylic. It does come in multiple sizes. I used to have the bum ones, but I think they've been on back order for quite some time. So they work really well on skin shearing. So if you have someone that's paraplegic or that's transferring all the time, and then they do a lot of shearing on their bum, or just they're scooting because they're trying to get to the edge of the bed, any of those types of shearing forces, this works great for. Also, they kind of stay on a little bit better sometimes than some of the foams. And they can actually stay on up to 3 weeks. So it also works really great on a skin tear, especially something that's linear, something that's not draining a lot. It's not going to work on someone that's got great big edematous limbs and then a tear, because that's obviously going to probably pour out a lot of fluid. But they do work really, really well on skin tears, especially the fragile skin that you're just trying to maintain it and just leave it alone. And yeah, by the time it's ready to come off, the edges lift quite easily because they've flaked enough skin off. But so we do. The only thing you have to be careful with is the film that's on the edge. That if you're having to change it more than twice a week, it's probably not the right dressing because it's not absorbent enough. But it works really great for stage 2 pressure injuries, for skin tears, as again any shearing injuries. So again, I used to use the bum ones, but then I'll just kind of patch and put different ones on depending on the area on the bottom. Okay.
Could you use it as tape as well, like if you had a small dressing to secure if they had really fragile skin?
Yes, you could. Especially if you're going to leave it on. The only thing you can't do with these is cut them, because the jelly stuff will leak out of it. So that's the only downfall to them. But I do have, like, again, I have them in like a tiny size up to this size. So at least you have some sizes to select from. I do still carry Duoderm because I have to. This is a Tegaderm hydrocolloid thin. I use it mainly for usually in ostomy care that we're using it. So if you're on the surgical floor, sometimes we do get some difficult ones. We had a lady; it was incredible. I really should put that picture up because she'd had a colostomy surgery done, and then they had done a resection, and there was an anastomosis that was before the colostomy, and that anastomosis burst and fistulated up on her abdomen. It was the craziest thing I've ever seen. And so she's got pieces of bowel hanging out pretty much everywhere on her stomach, and then these creases and crevices. And one of the only ways that I was able to actually get a handle on it was to actually use some of this Duoderm so you could cover and protect some of the skin, because there was so much drainage everywhere. So it does have its purpose. I don't use it a lot. I tend to stick with the acrylics, and also because they have that nice Tegaderm, or they have the Tegaderm film on the edge. But it is around, so it is still on all the floors. I think they will eventually phase it out. And it can stay on, I believe, up to 7 days, but again, it often doesn't stay that long. It does absorb a bit as well. So calcium alginate, I really should take out stock in it, because it's one of the things I probably use about 70% of the time. Why? Calcium alginate is a hemostatic agent, meaning it stops bleeding. So if you've got a bleeder, I keep this in my kid's hockey bag as a trainer, that I can pull this out. Any kid that's bleeding, it'll stop it. It's actually what they use in the Stop the Bleed for like paramedics. They have like this sheet, it's literally as long as my wingspan, but it's all balled up, that if they had like a big massive bleed, that's what they're putting in, is alginate to actually stop it. So we have two. I do carry this ribbon, which is a high integrity alginate, so it's a little more absorbent, and then there's a thin sheet that you can use as well, so depending on the amount of bleeding. I do a lot of debridement on the floor, so I usually take alginate in with me, so if I ever needed it. So again, big one is that it stops bleeding in about 15 seconds. It initiates the clotting mechanism right away. Also, it absorbs about 17 times its weight of fluid, so it's actually super absorbent. So then you end up being able to leave that dressing and leave it alone for a lot longer period. The manufacturers do say about 7 days, but again, other manufacturers are old times said 3 weeks, so I don't get too worried about leaving it longer than 7 days if I have to. If you have to soak off the alginate, then don't change it. Just leave it there and put a new dressing over top. That's the other big piece with it, because again, things will heal under the alginate. It will absorb as much of it absorbs the wound's own fluid, so that it kind of creates this blister effect. So it leaves the fluid at the wound so it can heal on its own. It's, again, used as a primary dressing, and what else did I miss? Nothing else, 7 days. So again, Keltistat is one that's woven, so there's biotin alginate. You might have seen it in multiple things. I've seen some buildings that don't even carry alginate, which I don't know if they have a wound program, or why they wouldn't, but it's definitely one of those things I use in a lot of areas. People get worried about packing it. So it is bioreabsorbable, meaning that if you do leave a little bit behind, because it actually is brown algae, your body will reabsorb it. Whereas some of the hydrofibers and other things, it won't. So you can irrigate this out. When you're using that pressure, if you've packed it into a hole, not one that's, that's 9 centimeters and you don't know where it's going, but something that's undermined, a few centimeters deep, you're quite able to pack that alginate in there and then irrigate it out well. So hydrofibers, so I only mentioned it because, again, we use the Aquacel Surgical, which are up in the top right corner, so they do come in multiple sizes. I know Dr. Lisa uses a lot on the abdomens. All the orthos use them for their hips and their knees. Again, and now if you're seeing one and it's completely saturated, post-op day 1, it might not be the right bandage, and then we will change it and put it into a more conventional dressing, especially, if there's a post-op seroma or there's hematoma or something else that's going on that we do need to monitor it a little bit closer. But for the most part, they're leaving these on and they're getting discharged home with them. They are about $50 a dressing, so we don't tend to give them a bunch, just to be aware. So yes, they are expensive, but it definitely beats conventional therapy if you were doing it every couple of days. And they're quite absorbent. So the hydrofiber, it actually wicks the fluid away. That's why I also put that picture up. So it keeps the moisture off the skin, and it works really, really well. The surgeons have definitely noticed an increase in surgical site, that they're healed quite well within that week, just because we've left it alone. So another big piece to why we're trying to reduce dressing changes. Again, we do have Axel, but not so much. So hypertonics. So we carry AMD or PBMH impregnated gauze. There's the big large roll, which is the Curlex. It also comes in packing. There's been a lot of back orders because of COVID still. So the AMD, I think I only have in a 1/4 inch, which I think I did grab some here too as well. So this is actually also backable. I don't know if that's a word. But we can use this under negative pressure wound therapy. If you've ever seen a wound that's got multiple tunnels and it's going in kind of all directions, to try to put regular granny foam in there, it's not usually ideal. So I have done a few gauze vacs with this. So if I'm ever saying Curlex, this is This is the Curlex that I'm talking about. And PBMH is basically a large molecule chlorhexidine, so it falls into that chlorhexidine class. So if they have, again, if they have a chlorhexidine allergy, because then this is not your choice, but it works for a lot of things. And I've used it just, again, with something stinky. You know, when you get like the cardiac related edema and their legs are just weeping, they're trying to get the diuresed, and it smells. Well, if you wrap whatever in with this, sometimes that actually helps get rid of some of the odor. So it's got multiple uses. Again, we only have 1/4 inch packing, but this packing can stay on up to 3 days. This can stay on up to 3 days. So sometimes it's not enough. We do still carry plain packing, like 2-inch vag packing, 1/2 inch and 1 inch that we can use as an alternative. A lot of agencies, we've had to do that lately. I've been either using iodine or Paradex mouthwash, which is a chlorhexidine base that you can soak it in. But the only problem with those, then you have to change it on a daily basis. But sometimes that's what we've had to do during COVID. We're not quite back to olden days, but we sometimes have to use some alternatives. So the other thing I do have is mee-salt. Mee-salt is a hypertonic, so it is a chemical debriding agent, and it will, it's mee-salt, we use it on something mucky, meaning that if it's mucky and gucky, mee-salt's the one. Works great for abscesses. Sometimes I will switch and use an Acticoat Flex because it's a high content silver, and it's going to help with odor better. But mee-salt, sometimes I will just hit it with mee-salt for about a week, clean up all the debris that's in the wound, especially if it's a big abscess, and then switch over to the Acticoat, and then combine the mee-salt with a charcoal dressing, so the charcoal will help with the odor. So packing of mee-salt, or packing of any type of packing, gone are the days that, well, not gone, but no one really kind of taught us to pack as novice nurses. Someone, you just watched the nurse that was before you, whoever you were consolidating with, and they would take the packing and just kind of push it in from the end, right? I'm sure most of you remember this, where they've got the packing out, and they take it and they just kind of, with their stick or whatever, their forceps, they would just push it in from the end of the wound. Well, I do really like to teach that that's actually probably not the most ideal way. So in the package, there does come 2 swabs, and that's why I would say, there's 2 swabs for a reason. One to probe, one to pack. So you always want to probe any wounds, and I know it's still something that makes most people nervous. But again, I've hung out with surgeons long enough; they stick their fingers in everything. So this little guy isn't going to do much, right? Like they're all, look how far it is, this is how far it is from the surface. So these are really not going to do anything. I've never seen one of these little tips come off. This is quite bendable. Like it's going to follow that track. So don't be afraid to probe. You're really not going to hurt them. Again, I've never seen anybody that's going, I just hit bowel and punctured it. Like that's not going to happen either. The fascia is usually there. It usually, that's the last part to go. So please probe them. Don't be afraid, because again, that's how you're going to feel if there's bone. Like again, osteomyelitis is real, and if you probe the bone, 90% likelihood, like why do all these tests? Let's just treat it. So
sometimes tunneling, like you can get it right in the right spot.
But then where, right? That's the other thing, because like I poke everything, so I'm always like, where does this go? And they're like, how do you know to poke that? I'm like, well, there's hypergranulation, there's probably a hole. So it is really good, so then you know which way you're going. And then you can actually document, say, tunneled, and they were so ingenious, they put a ruler on the back, so in these packages, so you can be like, tunneled 4 centimeters at 11 o'clock. Head is 12, your feet are 6, so you're always using a patient as a clock. So yes, probe those wounds. And then when you go to, so I actually use suture kits all the time. I think I brought them down. I'm always searching in this box. There's forceps in there. My little tickle trunk, like Mr. Dress Up. So I literally when I pack, I put a pair of forceps in. So in the dressing trays, there's often I just literally grab the suture kit and my swab. So after I probe, so I know which direction I'm going. When I do it, so now I know, again, if it's 4 centimeters, I know I got to go that far. All I really want you to do is pack to the base. You don't, it doesn't matter how much packing you get in, it matters that you've got to the bottom of the wound. So I tend to just fold over my packing, and then I'm able to get all the way in. Like I end up pushing that packing all the way down to the base. And again, I always say loose as a goose, not tight like a turkey. Like we're not trying to stuff this because that can actually hold the wound open. If you put so much in, it actually puts pressure on the wound edges and that holds it open. So again, if you can get that to the base of that wound, that's what's gonna heal it. And you're gonna draw all the other abscess fluid and muck and guck out of the bottom to the surface so it will granulate up from the bottom. That's my soapbox on packing. So again, 2 swabs and a ruler, that's all you need. Anyhow, so Measalt we do pack, you know, I use it quite a bit to begin with, and it draws all that fluid out, so you'll actually see it start to crawl the Measalt before you're even done. And lots more ramblings about that there. And then secondary dressing. So after we put packing in or we put Iodosorb on, I'll talk a bit more about some of the other topicals. The secondary dressings. So again, good old ABDs we can still use them. Mesorb is almost the same, it's a little bit more absorbent. And good old Telfa, we still keep Telfa on the floor. Telfa's a non-adherent. And it works really well, especially if you have some traumatic injury, that it will help to just not stick when you go take the old dressing off. And you can put Telfa under these. So Mesorb, again, it's kind of like a souped up abdominal pad, and then there's Mextra. So they look very similar, only the Mextra is like a diaper technology. So it's the same stuff that's in a baby's diaper. They also ask you not to cut this. The Mesorb will cut and it'll actually seal. That's what I had this. You can actually, when you cut it, it will make a seal on the fluff that's inside. This won't. It'll have all these little beads will come out, and you'll be like, what's all this jelly in the wound? So yeah, don't cut them extra. Mesorb's fine to cut. As much as the Molinecky will tell you, no, you're not supposed to cut any of it. Well, they also don't make them this big, so it sometimes has to be cut. Anyhow, so this comes in multiple sizes. I have really big ones, I have little ones. So just choose, because again, as much as this absorbs twice as much, it also costs twice as much. So, you know, just to be a little bit fiscally responsible. And again, it can stay on up to a week, but for the most part, if you're using these big ones, you're probably changing them twice a week. Sometimes they're daily. It really just depends on the amount of exudate that's coming out. And then foam. So I also get to keep different foams here. So we use 3M products, if you've not noticed. I have Tegaderm. This is, again, it's that film, just kind of like that clear acrylic, but it has the film on it. So these sometimes actually stay a little bit better. That film, I don't know why, it just grabs a bit more, and especially if it's on the posterior surface, I think just the heat from them laying, it just helps us kind of melt down and sticks really, really well. When you have a small wound, always use something that's twice the size. So I do see that sometimes where, they have a little wound, then because I have other ovals that are about half the size, and they have this little wee dressing on, put that big dressing on. What this does is actually help to redistribute some of the pressure, because especially if they have that little pinpoint, well, you want to try to offload that a bit. So don't be afraid to use bigger dressings, especially on the backside. So these also have anchors on them. Because of the Tegaderm, it'd be really wobbly, so the paper all comes off. It does show you on here, like the picture of it, and then it's actually all cracked, so after you kind of slap it on, then the paper comes off. Okay. And then I do have silicones, again, also this is the largest size, and then there's a 3x3 and a 4x4, so there is some smaller ones. Silicone I do try to reserve for those that do have tape allergies, if their skin is really fragile. The reason why sometimes I will use this one, even on fragile skin though, is because this is non-adhesive. So the whole surface, like that's actually in contact with the patient, it's not sticky other than the tape edge. Where the silicones, they have tape, silicone, on the whole surface of the foam. So that in itself can be traumatic coming off. Again, these are something that you want to leave on, you want it on a wound that's exudating, moderately, because you want to only change these maybe twice a week. They are a little bit more expensive than perhaps the blue pads, because if you're changing these on a daily basis, it's probably the wrong dressing. You probably want to go to one of the blue ones. But again, they can also be left on for up to a week, so when they are just kind of that mild to moderate, these are a good choice because you can just leave it alone and things heal kind of on its own. Okay, that's my bit on foams. And then I also carry Biotane IBU. Biotane IBU is a non-adhesive foam, so there's no sticky on it whatsoever. You have to add your own tape. No more than one layer of film, but sometimes we're just using Methatac or silicone tape because of trauma. The reason why this is significant is because it does contain ibuprofen, so 0.5 milligrams, which is very small. So again, when you put something topically versus ingest it, you need a much smaller dose. So it's really effective on ischemic limbs, but it the wound has to be open. It has to come in contact with fluid. I only say that because I've said that before, and then people have just put Biotin all over my legs, like, my leg hurts, so she puts this on, and I'm like, but there's no wound there. There's just, it's not going to transfer any IBU unless there's moisture that comes in contact with the dressing. So I will use that, especially if something is ischemic and we're trying to dry it out, but not that it's too wet, but they're gangrenous toes. But again, it can help with a bit of hypoxia, because if you reduce the pain, again, you get a little bit better blood flow. So I do carry them in the larger sheet. Then you can cut the sheet as to whatever shape or size you need it to be. But yeah, it's a really great product. The other thing I will sometimes use if something is highly exudating, I'll actually snip holes in the back of this and then put an extra over top, because again, they get that pain relief plus some more absorbency. Otherwise, it'll kind of come out this side. That's why I cut the slits. Okay, and it can stay on, believe it or not, a week as well. Then Methatac is the same, so the silicone tape that goes around it, again, for someone that has tape allergy, this works really great. This is the other stuff you can use if you have really fragile skin and you're putting an IV in. So they will hold it down as well. I only carry the 1 inch, but it's a little bit smaller than your Metapore transport tape that you can tear easy. You do have to cut this, like it comes in a big box. I have one here. That you have to cut it, but it works great for anybody that has super fragile skin, or again just as latex or to other tape allergies. That comes in, I'm allergic to paper tape, and I'm allergic to Hypafix and all that stuff. I don't know, talk about sodium nitrate. Actisorb silver. So I always find the advertising sometimes is you got to read the fine print. So if you read it, it says, oh, it's silver. Well, it's got literally 1 UG of silver, which is almost the lowest amount you can put in anything. It's not the silver, it's charcoal. So right below it does say activated charcoal dressing. So this really works for odor. I don't really use it for much else. Oh, studies show you can wrap it around a G-tube and it works great. It doesn't. So disclaimer. So its primary role is to make things less smelly. So the other thing I will do with it is sometimes I'll slit the back of the Mesorb and I'll actually put it in the back, because the charcoal tends to deactivate. That they keep telling me this is the only one that doesn't, but everyone else does. The charcoal deactivates after it gets wet. So when I put it on the last layer, the last thing that, lots of fluff, the last layer, then it lasts longer. So just to tuck it in, and that they get some odor relief. I do like to try to review some of the other ointments that I use. Flamazine is one of them. I still use it for burns, especially kids, just because kids sometimes you do have to make dressing changes more often, especially if they're great big bullas or whatnot. That again, Flamazine is it's just basically silver in a cream, but it has to be applied twice a day. That's the only problem with it. The shelf life is also only about a week, so whatever, we have mini tubes. That's why you'll never see a big tube of Flamazine here. That we will use this for. I often transition kids to honey, but I have to get them to home care first, because honey's like $60 a tube, so I let them pay for it. And we'll use Flamazine for short term till they get there. And again, if they're like burns, are often highly exudated to start, so sometimes this is just a better option. So just to be aware of that again, and then the tube should be thrown out after a week, because you're just putting cream on. There's the silver's pretty much fully evaporated by then. Again, and so that's MetaHoney. As I said, you might see me, I do have samples and stuff, but I don't use it a lot, because again, if they're coming in with a burn, usually they're into immersion and away they go. But it's literally honey from this tree in Australia, and it works really, really well. I have tasted it. It's literally, I could be spreading it on my toast, but I don't know why this particular honey versus, whatever's made in North America. And I know lots of people that have just put their honey that they made from the back beehive that they have, that it seems to work too. And it does have an antibactericidal property, so it doesn't cover the same amount of microbes as some of like the silvers and whatnot, but it can be a very effective antimicrobial. Hydrofair Blue, you may see it. So I do use the ostomy ring sometimes when we have peristomal issues, when they've got irritant contact dermatitis. So it's basically this, what is this blue thing that she's got on here? So just to be aware that it's there. It's basically a polyvinyl alcohol with methylene blue that's impregnated into it. When you're applying it onto a patient, it does have to be moistened with sterile water. That's really the only big piece to it. And then Inidine. Inidine, when in doubt, put Inidine on it. Why? It's $2 a sheet, and you're not going to hurt anybody with it. So our iodophores of today are not the same as what your mom or grandma had, because back in the 60s, iodine actually contained alcohol as well. So the iodophores were a little bit different, and they were considered cytotoxic. Where we've refined things a little bit, I guess, in the 20th century and the 21st century, and they're not considered as cytotoxic. So again, Inidine won't dry out an already wet wound, but it will maintain a dry wound. If that makes sense. So they won't think, oh, just put iodine, it's going to dry it out. Well, it really depends on how much it's exudated. I will use it especially on gangrenous toes when I'm trying to get something from wet gangrene to dry gangrene. I still find betadine works almost a little bit better. You just paint it and it helps to dry it. But again, no matter what you've got, and you're like, I don't know what, I remember Jen rambled on for an hour about stuff. When in doubt, put Inidine on it. Okay. You can pack it. I don't really. Oh yeah, that turns white and all that stuff. I think you can read all that. Again, so iodine, you will see me use a lot of it. The other reason is because iodine is the smallest molecule of all the antimicrobials, so it penetrates bacteria better than silver, than methylene blue, than chlorhexidine. So it is one of those antimicrobials that I kind of, I won't say I have a bias, but I tend to lean towards, because when something is really chronically infected, and because we see lots of people that come in, that they've this revolving door from community to here, they get cellulitic. So I do carry it in swabs. You'll see them around the floors. There's like 3 in a pack, and then there's also bottles of it on most of them as well. And again, I will pack with it too. So you'll dip your packing in and use the iodine. Silvers, I do caution because again, the bone will absorb some of the silver. It's okay if it comes in contact with iodine, because iodine is naturally occurring in your body, whereas silver, when too much of it, it will actually turn you silver, that blue hue. So it can cause a burning sensation when handled, so always have gloves on. And again, we can use the low-dose silver dressings for over 4 weeks. I know there's a lot of chat out there about, oh, we don't want to, just like antibiotics become, get things building resistance. Well, I'm sorry, if somebody's got a diabetic wet foot ulcer that they're having to change every day, they need some antimicrobial in there, especially if, I'm not going to be able to heal this because of 15 other factors. I've had people maintain with silvers for several years, because that's how we've had to manage them. So it's not ideal, but in perfect world, in a shoe, you need something. Again, it's also very effective for odor, and I do use it for abscesses a lot. So Acticoat Flex is the big one. Flex 7 is, it's very, very durable. Let's say I have it in here. Then I'll just, then I tell you not to use it with gloves, and then I go and I stretch it. That's why I try to keep the picture up. Of course I don't have it. Like, every time I think I fill this box, I'm like, I'm missing this and I'm missing that. I really need to go through it. Anyways, it is very stretchy. You can cut it as well. So when I cut it, I'll actually, like, if it was a sheet that was this size, I'd cut a strip here, and then I'd go and I'd stop, and then I'd cut down here, and then I can actually eventually make this whole thing like one long big strip. That's why I don't carry multiple. I just have the 4x5 sheets. And again, it can stay on for up to 7 days. The difference with Acticoat is it's 110 UGs of silver, so it's my highest content silver I think that's on the market. So I also use it when we've got something that they're septic, or it's very cellulitic, or I just need to treat it topically quickly. It actually drops all the silver, and then it slowly dissipates down. And again, and it's quite packable. You can use it on all kinds of stuff. Silvercell is a hydroalginate. So when we go back to what the Aquacell does, Hydrofibers is a man-made alginate, and you can't leave it behind. So this has a bit of alginate as well as the man-made one, so you just have to be careful that you pull out any of the fibers of the Silvercell if it gets left in anywhere. I do carry it in, again, 3x5s and 4x8s. You'll often see me after I've debrided a big bum, is that I'll stick a great big sheet of silver cell in, because that's going to help debride the remaining devitalized tissue. And that, again, any gelling dressing, that's one of the things that it does do, and it helps with that autolytic debridement. And it's really good for odor. So it's 15 to 40 UGs of silver, so it's a lot less than the Acticoat, so it tends to be kind of my medium road silver. And again, it can stay into up to 7 days. And I'm sure you guys might have seen other ones, such as like, I don't know, there's Biotane AG, there's, you know, there's all other brands. It's all really just the same thing. There's a Tegaderm AG, which I find is kind of flimsy. So this is just the one I've stuck with, and it kind of also helps me transfer to community. So it's nice to, you know, I'm not changing it like, what is this? Is it the same as this? And, you know, so then that's because of what they have. Again, so there's silver foams. You will see me kicking around with them. They look very similar to the Biotane AG, only they're gray. So you may see them on the floors. I don't use them much. I tend to use the silver cell or use a different product combined with it. Cavalon. So I do carry Cavalon spray, wipes, and ointment. So, or the like barrier cream. So they're on all the floors. The Cavalon spray works good just as a coating itself on a bum, especially if you got a stage 1 or something. It works really well. You can use the actual barrier cream. They're just in little sample bottle sizes, but they're on all the floors, so they work really well for that. There's also the wipes. The wipes are apparently supposed to cover a whole abdomen, but I think my size abdomen and your size abdomen might be a little different. So again, I think it's for a regular size. So they are around too if you're trying to get Cavalon in and just as a skin protectant. I always use Cavalon under negative pressure. A, it helps the drape stick. B, it helps the drape come off, so there's less skin tears. You can also use it under the Tegaderm foam. So you're not supposed to use it under here because it's basically a silicone in a spray. So silicone on silicone, this actually will affect how this adheres. However, it works great at tacking this down. So, and it coming off. So it just one of those things to keep in mind. And then I also have the lovely chart, so it does kind of put everything into those categories. So what adds moisture, what removes moisture, and what maintains it, all the different dressing types, and the amount of silver in it, so that you can also, there's some that are comparable, like if you're used to Tegaderm AG Mesh, well, it's the same as Acticoat Flex, only it has a little bit less silver. So it's another way for you to be like, remember we used to do this product? So I have a lot of them on there. If there's any that isn't, let me know and I can always stick it in. But I think it's most of them that are kicking around. Sometimes talk about measuring, but I won't today. I think iodosorb ointment I still have to add in there. I do carry it in here. So iodosorb ointment, you will see them on the floor as well. It's Condexamer iodine. It has like these little beads in it. Everybody calls it the baby poop. They're like, oh, that looks like baby poop. Like 90% of people say that to me. So this is also a chemical debriding agent. So what it will do is actually exchange moisture for iodine. So when it comes in contact with moisture, it will open this little bead, dump the iodine, and then gobble up about 3 times the amount of moisture. So when you go to take it off, people say, oh, they were supposed to put this gel on. Well, it's usually white, it's clear. It looks like you're actually put Intrasite on, just to be aware of that. It works really, really good at aggressively debriding some things that, especially if the patient won't tolerate it, and or removing biofilm. So biofilm is, you know, when this polysaccharide extracellular matrix that develops after something's been chronically open for a long period of time. And this is the only thing that kind of really pokes through it. So you want to put this on about a dime's thickness, so it's really fairly thin, and it's really hard to work with. So I love my little swab sticks, and I kind of roll it on with the Q-tip, and then you can kind of reuse the tubes, because you know I don't really like touching tubes on patients. Not that you're going to use that one on another patient, but at least it keeps it cleaner for that patient, and then the tubes can stay with them. So yeah, that's most of my stuff on dressings. Am I till 3 or am I till?
You're until 3.
Perfect, so I'll do a little bit of compression. We're probably one of the few acute care facilities, only because we're small enough that I can actually keep kind of control of the compression program, that actually has, you know, we use Tubigrip, we have Comprolon, and we have Coban 2. The, where's my Comprolon? I saw it in here. Oh, I lied. Did I take it out? No. Anyhow, so Comprolon, the kind of the big difference that I talk about with the different compressions is Coban is for when you're changing it twice a week, so something that's not overly heavily exudating. When you have, again, those leaky legs, cardiac-related edema, or they've got cirrhosis and they're just full of fluid, and they're leaking, I switch to Comperlon. Comperlon looks very much like a tensor, and they come in 8-inch and 10-inch. So inside the package, sorry, I don't know why I don't have it with me. Anyways, inside the package, there's 2 methods on how to apply it. One's, it says method 1 and then method 2. So you'll actually see me write in instructions. Please apply 8 centimeter Comperlon via method 1, then apply 10 centimeter Comperlon via method 2. I do have a Comperlon video on there, so then that's kind of nice. I don't have to go through all that with you, but it's basically where you're going to start at the ankle, work the tensor or the compression down the foot and then back up the foot. Sometimes it'll come up the leg, but then your second one is to start the toes and up. So it's to produce what's called graduated compression. Graduated compression means that it's higher pressure at the ankle than it is at the knee, so that you're going to push and move that fluid up. That's what's going to treat it. Venous leg ulcers, even traumatic injuries. There's lots of things that, again, if you have that, the pressure or the fluid retention in there, you're not going to heal it. There's too much stress on the tissues. So the compression is kind of the primary treatment. So sometimes it doesn't matter what you put on, it's the compression. Anyway, so Comperlon, it'd be good to look at the video for it. Tubi grip, I do have in 4 sizes. D is for the arms for the most part. So if somebody has, but again, skinny arm. Because again, if you have lymphedema in an arm, you might need to use a G. There is a sizing guide. It's also, so I have 3 folders in, on the shared folders. One's for wound, one's for ostomy, and there's one for back. That if you go into a wound, you'll actually see the compression, and there's a little guide inside of it that tells you, okay, G is this many centimeters. So if you're measuring a calf, and it shows you how to measure depending on what limb it is. This is, if it's 26 centimeters, you're going to use a size E. If it's 38 centimeters, you're going to use a size G. So you don't want to have to retain that information. At least it's there. The only problem with the Tubi grip is, though, you can't put on anybody with latex, because there is a little bit of latex in the actual elastic bands that provide the compression. So that's really the only thing to measure, or to think of. But again, it works for the majority of people. I also have how to apply them, as well as how to apply TED stockings. It's a good old trick. Anybody want to give me a leg? I'll show you how.
Sure.
Perfect. So Tubi grip, for the most part, every layer of Tubi grip is 8 milligrams of mercury of pressure. So normal people, like again, when we get socks, I always get socks that are about 15 milligrams of mercury. You can buy those over the counter. So 2 layers of this is about the same. So when I go to apply a Tubi grip, I'm often putting 2 layers on. So I take the first layer and I go inside out. And I always tend to put this part at the toes, so it's not flaking all over. And then what I want to do is I want to flip it inside out. If you want to give me a leg, so I want this edge right at the base of her toes. So I want to push it in, and you can actually, if you can get enough in and you get it over the foot, it actually goes on a lot easier. Then you're not doing this struggle. So if I get it to the foot and just over the heel, and then I can bunch up the rest of this, and you literally pull up. Right? Is that the least amount of struggle you've ever seen go to have a sock go on? Yeah. So it's just that you want to turn that foot piece inside, and then they feel great. Yeah, your feet are cold. You can keep them on if you want. But it works the same with TED stockings, right? I was an old surgical nurse then. Man, those were fun. And it was, somebody showed me, I'm like, this is amazing. Like you put it over, all you have to do is get up over the foot, and then it just way up it goes. So just to help you not struggle is.
How did you do that?
And there is a video for it too.
Put your arm in.
So I put my arm in and I made it to, yeah. So I pulled it off the top of my arm. Pull it from here, and then that'll flip over. So hold it, yeah, here you go. Yeah. Pretty neat, eh? I know, and then you get the bits all over. Yeah, so then the next is Coban. Again, there's a video for Coben as well. So I just still like to chat a little bit about it. So there's a green box and then there's a purple box. Green box is 15 to 20 milligrams of mercury. Purple box is 30 to 40 milligrams of mercury pressure. You can't put the purple box on without some sort of ABI or vascular study. This can go on anybody. Like, this is, again, you buy this over the counter for the most part. Yes, you still have to get an order. However, this is the one that I start everybody in to also to develop tolerance. Because if I put somebody in, you know, it's got legs this big in 30 to 40 right away, they're not going to be real happy with me, especially if they weren't used to compression. So I always tend to start with the green and then we move up to the purple. This little black sock is completely optional. So it's not, all this does is make the Coban not stick to the bed sheets. So it doesn't actually offer any compression. It's just there. It's an optional thing because some people, I don't want my toes covered, and you know, so it's fine if they don't have it. It's not, you must have this. So anyhow, so again, there is a video on how to apply Coban. Again, and I was one of those nurses that I read all the instructions in the box. Like when I get something new, I'm like, oh my god. So it is in here too if you need a guide. But at the same time, it is really nice if you just watch a video and you're like, oh, well that's.
Yeah, I don't
way
read
easier.
instructions in the box.
Well, right. Then there's that too. You get around long enough that you just you throw the instructions, right? So yeah, that's my little bit about compression. As I said, there is TED socks around too, and I put them on pretty much the same as the Tubigrip. I can put Coban on for you, but
Now, for compression, we're able to apply, or do you have to?
no.
do
I
the
guess I mean you don't have to call me. Like that's what I'm saying. If you want to put Tubigrip on them, put some Tubigrip on them.
Yeah.
But measure. Make sure again if you're putting on a lower leg that you're actually measuring the calf.
Okay.
And then that little chart is on shared folders that you can look. Okay, I need size. There's D, E, F, or G. So this one is E. So this is one of the smaller ones. Like the G is almost this big. So yeah, it's something you're able to apply.
Awesome. Yeah, that's different for me.
It is. That
Yes.
no, it's like, oh no, there comes syrup. Well, no, if you're gonna put purple box on, yes, Jen has to look at that.
Okay.
But anything below that, you're okay to put on. Yeah, and as I said, the Comprelon, it is nice to watch because again, it's a short stretch bandage. You really can't screw it up. Just don't put tensors on people because tensors are uneven because, you know, one rip is gonna be all the way out here and then you're wrapping around and then the next one you're like, oh, I'm tired. Oh, somebody asked me something and it's just never even. So again, you really can't mess up the short stretch because you don't need to pull it. You just have to put it on. Then it'll kind of shrink down when you have the multi-layers on because it's that multi-layer that provides the compression. So yeah, so again, you can put that stuff on. Feel free. Any questions? I know I talk a lot. I talk pretty fast, but at the same time, this is old hat for me at this point. Right.
That's awesome.
No questions?
No.
Sometimes I do negative pressure too, but that's a lot.